Good afternoon, students. Today I'll see about thoracic outlet syndrome, a physical therapy management approach. First, what is thoracic outlet syndrome? Is a condition resulting from the compression of neurovascular bundle in the thoracic outlet. It's often the misdiagnosed, but physical therapy offers the primary conservative management strategy. Then understanding the thoracic outlet syndrome. The neurogenic thoracic outlet syndrome involves the compression of brachial flexus. That is accounting for 90% of the cases. Then venous thoracic outlet syndrome involves the compression of the subclavian vein seen in the about 5% of the cases. Symptoms include swelling and discoloration. Then arterial thoracic outlet syndrome involves the compression of subclavian artery, the rarest type of the less than 1%. The common cause of include cervical rib and muscle hypertrophy, that is a scalene muscle and pectoralis minor muscles. Trauma and poor most posture, then pain, numbness and weakness and tingling in the arm and hand. Then PT assessment and diagnosis in the thoracic outlet syndrome. The subjective and objective examination. The subjective history will mainly detail in inquiry into the overhead activities, sustained posture, then history of trauma and precise distribution of the symptoms. Then posture analysis. The assessment of the common deviations such as forward hip posture, rounded shoulder, then depressed shoulder girdle. Then palpation. It's identifying the tenderness or hypertonicity in the key muscles like scalene and pectoralis minor and subclavius muscles. Then we'll go for specialized tests. Then there are physical therapists utilize a specific diagnostic maneuver to confirm the thoracic outlet syndrome and differentiate them from other conditions. The first one is a Hudson test. This is evaluate the scalene muscle involvement. The Roche test is the eye sensitivity test for 90% of our neurogenic thoracic outlet syndrome, assessing the endurance with elevated arm. Then writing test is specifically assess the compression of the pectoralis minor. Then comparative tension test. You rule out the specific peripheral nerve entrapment. Then core principles and conservative management. Core principles and conservative physiotherapy management. The decompression and the restoration. That is the primary goal is to decompression of the neurovascular bundle structure and restore the optimal function and significantly reduce the pain. Then duration and key areas. The initial conservative treatment typically span for 6 to 12 weeks, that is 1.5 months to 3 weeks, 3 months. Then focusing on the postural correction and muscle balance and mobility. Then high success rate. Conservative physical therapy demonstrates the 70 to 90% of the success rate in the neurogenic thoracic outlet syndrome cases, making it a highly effective and first line of the approaches. Then targeted physiotherapy intervention, the mobility and strength. The stretching protocol, the targeted stretches for the scalene muscle, that is a lateral flexion of the head rotation. Then pectoralis minor, that is a corner stretch. There is a crucial held for 30 second holding, 3 to 5 repetition. Also there is a cervical extensors and levator scapulae. Then we'll go for the manual therapy. There is a technique such as a soft tissue release for the scalene muscles and pectoralis minor muscle, first mobilization, then thoracic spine manipulation for the applied to address restriction. Then nerve glide and mobility. Then mainly for median nerve, ulnar nerve, radial nerve, or glide for performed for 10 to 15 repetition across the 2 to 3 sets to the enhance neurodynamics and reduce the nerve impingement. Then strengthening exercises, mainly focused on the deep cervical flexor, that is a chin tuck exercise, and scapular stabilizers like lower trapezius, serratus anterior. So there is a slide, Fuso plus, which is a focus on the endurance type of the exercise. These are adjunctive therapy for the modalities that relieves the pain relief modalities. That is main for needling. First one is the needling. First feature is the needling. Second is the hot water factor moisturizing therapy. Then third one is the manual therapy. That is the manual therapy. Okay. Then we'll go for the fourth feature is the Maitland approaches. The Maitland belt mobilization. The draining will target the myofascial trigger point in the affected muscle, potentially reducing the 40 to 60%. The therapeutic modalities, the second feature is like the heat up modalities like the pain relief. And IASTM and cupping are also facial restrictions with while kinesiotaping offer for postural support and muscle facilitation. Then patient education and self-management. First one is the ergonomic adjustment. That is optimize workstation setup, then avoid prolonged overhead activities and restrictive for arm position to minimize the compressions. Then activity modification. Learn to face activities. Avoid the repetitive task. Then and manage the lifting load to prevent the symptom exacerbation. Then third is the breathing mechanics. That is a practice a diaphragmatic breathing exercise for 5 to 10 minutes daily to reduce the overuse accessory respiratory muscle like scaling. Then home exercise program. That is adherence to the consistent home exercise program is crucial for sustained progress and long-term pain relief. Then symptom monitoring. Develop the ability to even is exacerbating the factors and adjust the activities then accordingly to manage the symptom effectively. Then we will go for conclusion point. The conclusion will be empowering the recovery and prevention. The consultative physical therapy is highly effective first line of the management neurogenic thoracic outlet syndrome. A multi-faceted approach to addressing the posture, muscle balance, and nerve mobility. That is the key factors. The patient engagement and the adherence to the home exercise program are crucial for long-term success. The surgical consultation is considered if the consultation fail after 3 to 6 months